Currently starting our course with the topic critical care, respiration and ventilation, and the speaker will be Dr. Vinod Kumar Singh, Sir Gangaram Hospital, New Delhi. And may I invite chairpersons Dr. J.C. Pandey, Head of Anesthesia, Ruben Patliputra, Dr. Hai for the chairperson, and Dr. Ashutosh Jha, Professor Anesthesia, Katihar Medical College.
I don't think he needs any introduction to an audience to be heard. He has been a favorite speaker, and we always look forward to his deliberations. And with these words, I welcome you, sir, to this talk and request you to proceed with you.
Thank you, sir. At the outset, I would like to thank all the members of the organizing committee and particularly Kishore for the organization of Criticon 2015, the annual practice update. And most important thing, I'm delighted to see the response and the changes in the HMRI hospital and HMRI Paras hospital. The last time when we came for the ventilator workshop, it was like a little bit disorganized, but this time I'm happy to see the more importantly the response from the younger people. So when I got a topic from the Kishore, that respiratory medicine and mechanical ventilation, I was a little bit confused what to do for this type of topic and which is the most relevant thing to discuss. Then I decided to discuss the ventilation strategy in ARDS because in last 5 years or so, there has been tremendous change in the management and diagnosis, even the definition of ARDS. And it is more important because now we can see there is an epidemic ongoing with H1N1, which primary manifestation is ARDS, acute respiratory distress syndrome. That is the reason why I selected this topic, how to ventilate the patients of ARDS, what are the changes has come in the clinical practice of ARDS. So we'll start with the definition of ARDS. The ARDS is defined broadly or in general as acute lung inflammation. That could be due to many causes. That could be extrapulmonary cause like sepsis, or it could be a pulmonary cause, pneumonia, viral pneumonias. These things can precipitate acute lung inflammation and can cause diffuse lung injury. Meaning diffuse lung injury involving almost all areas of the lung and both endothelial as well as the epithelium of the lung, which manifest clinically as hypoxemia, which is usually refractory to oxygen supplement, and decreased lung compliance. If you put the patient on ventilator, you will find that it is very difficult to ventilate. This is the way how you are going to recognize the patients of acute respiratory distress syndrome. Now, what are the important things? What are the ventilator strategy when you're trying to ventilate this patient? The most important thing which is the most important thing that we are lung protection or lung protective ventilation, which is very important, and that has actually changed the outcome of acute respiratory distress syndrome. Second is adjunct to the lung protective ventilation. Sometimes you find that the patient is not improving on conventional ventilation. We have started the ventilating the patient, but the oxygen level is not improving. What to do in such type of patients, that I am going to discuss. What are the alternative modes of ventilation and what are the alternative modes of gas exchange even in such patients? That I am going to discuss. But the goal is very important. Whatever the strategy, whatever the method you are going to use to ventilate a ARDS patient, be very clear in your mind. The first goal is to protect the lung. We'll come to know why it is very important. And then to optimize the gas exchange. You don't have to normalize the gas exchange. We have to optimize the gas exchange and rest to the lung. These are the main goal when we are ventilating the patients of ARDS. Now, let us start with the case, and I would like you to interact with these cases. A 50-year-old gentleman, 80 kg, 60 inches, and a known case of hypertension presented on 30 January 2013 with complaint of breathlessness, cough, sore throat and fever for 4 days. He had tachycardia, increased respiratory rate, his saturation was 62%, chest bilateral basal clefts, ABG severe hypoxemia, and chest X-ray bilateral lower zones infiltrate and conscious stable hemodynamics. If you look at the ABG, the pH is 7.52, PaCO2 is 33.5, and PO2 45.0, and FiO2 and high flow of oxygen. Obviously, this patient was not intubated at that time, and he was on high flow oxygen. So if you're looking at the presentation, you can see this patient has got a severe hypoxemia. And also the patient has got a bilateral chest infiltrates. So I look at this is the chest X-ray. If you look, it is not very typical of ARDS because sometimes H1N1 will have presentation that is slightly different from actual what you have learned in ARDS X-rays. But this was the X-ray of the patients. So my question to you people, does this patient have ARDS or not? That is very important to understand because that changed the treatment and that's changed the prognosis. Now, how many of you are working in intensive care? So does the patient has got ARDS or not? Anybody? Yes. So this patient, we'll discuss why this patient has got ARDS. Because the ARDS was first described, if you remember, in 1967, and it's the Aspa et al. Who published 12 case series in Lancet, and he described ARDS in those people who has got a high risk factor. All the patient has a refractory hypoxemia and bilateral infiltrates, and he did 7 autopsy, and he found the most important pathological finding was hyaline membrane. After that, there was no much organized definition, but in 1994, the American European Consensus Conference tried to define the ARDS, and based on this definition, acute onset of hypoxemia with bilateral chest infiltrates, exclusion of the heart failure, that is very important. And that time when this definition was there, most of the ARDS people will be managed with pulmonary artery catheter. So they give the definition of pulmonary artery wedge pressure less than 18 mm of Hg or clinically no heart failure. Further, the patient who has a PaO to FiO2 ratio of less than 200 will define as ARDS, and patient who had PaO to FiO2 ratio more than 300, actually it is wrong, 300, they are defined as acute lung injury. Now based on this definition, if you go to the case, you can easily say based on the chest X-ray findings and the clinical manifestations, this patient has got ARDS. But what actually has changed in last 2-3 years? There are a lot of limitations of AECC definitions. So the Berlin definition came in the picture, and actually if you look at the Berlin definition also has got linked with the AECC definition, and there are more refinement in the Berlin definition. The timing has been refined. The timing says that within 1 week of known clinical insult or a new worsening respiratory symptoms, the chest imaging also, if the patient has got a bilateral opacity which is not fully explained by the other possibility like lung collapse or nodules. Origin of edema, they have also redefined the origin of edema. It should be non-cardiogenic rather than the cardiogenic, and this is the most important development. The oxygenation has been redefined, and based on the PaO to FiO2 ratio, the ARDS can be defined as mild, moderate and severe form of ARDS, and that predicts how the patient has, what is the outcome of the patient on the basis of the PaO to FiO2 ratio. So there are change in the definition of ARDS, and now for all practical purposes, for all research purpose and for all clinical treatment, the Berlin definition is in place. So Berlin definition has got better predictive value, better recognition of ARDS, and also has got a better, it is also presenting as a better research tool for the more research in ARDS patients. Now coming to the ventilatory strategy, how to ventilate this type of patient, what mode you are going to select, what is the tidal volume you are going to take, respiratory rate setting, PEEP and targets. But before going to think about the ventilator setting, let us think what happens in ARDS. Now if you look at the ARDS lung, which looks very homogeneous in the chest X-ray, in the CT scan it is quite heterogeneous. And actually, if if you look at the CT cut, which was first demonstrated with Gaetano in 1980, he demonstrated that the ARDS lung can be divided, or acute lung injury can be divided functionally into three zones, A, C and B. The A is the most dependent part of the lung, which remains collapsed. Whatever the tidal volume will be, it is not going to take part in the ventilation. The C, which is the middle part of the, or which is the part which takes in the ventilation or takes part in the ventilation, has got repeated opening and collapse. And the most important part is B, which he described as the baby lung, and it's give the baby lung concept that this part is actually the part that gets involved in the tidal ventilation. And he demonstrated the hypothesis that the ARDS is actually a baby lung, and it is a small lung rather than the stiff lung. So if you are trying to ventilate on the principle of the stiff lung, we are going to injure the small part or the baby lung part. For more delineation or more explanation, if you try to ventilate the baby lung with a high tidal volume or a normal tidal volume, this will create a volume trauma or a injury to the baby lung. Because see, if the lung capacity is like a baby of 5 to 6 years, and you are trying to ventilate this patient with an adult lung, this obviously is going to injure this part of the lung. So we have a hypothesis that the ARDS lungs should be ventilated according to this principle. Also, a repeated opening and closing of the alveoli can cause a shear injury, and that can cause a electrotrauma. A chronic collapse injury can also occur in ARDS. The part which is not taking in the ventilation remains collapsed throughout the tidal ventilation. So all these can precipitate a further lung injury if you are setting an inappropriate ventilation in such type of patients. So what mechanical ventilation can do? We all know that mechanical ventilation is life-saving. It provides gas exchange, but it is harmful also, particularly in such patients. If you look at this, the mechanical ventilation can cause a biophysical injury. If it is said inappropriate, that can cause over-distension, cyclic stretch and shear injury to the lung. Besides that, it can also produce a biochemical injury, a biotrauma, and can stimulate a pro-inflammatory cascade. Both combinedly can lead to ventilator-induced lung injury and multi-organ failure. And that is not surprised why patients of ARDS usually does not die due to the hypoxemia. They are dying due to the multi-organ failure, and that is probably the one reason why the patients of ARDS die due to the multi-organ failure. Mostly it is ventilator-induced lung injury. So how we can incorporate these basic findings in our clinical practice? If you look at the PD curve, the pressure volume curve in a patient with ARDS, which is an idealized curve, you can find there are 2 points, the upper point which is called the upper inflection point and the lower point which is called the lower inflection point. In between the upper and lower inflection point, there is a steep rise in the compliance of the lung, and ideally the ventilation target should be this area of the lung. If you are going here more above the upper inflection point, we'll try to injure the baby lung. If you are going not setting an adequate peak in such patients, might produce a repeated opening and collapse injury or the shear injury to the lung. So what is the best ventilation strategy in such patient? To ventilate the patient between LIP and UIP, but this is not easy. Most of the ARDS patients might find in such type of ideal graph, but in many patients who are difficult to ventilate, this graph may not be there. So there may be some other way of finding this graph, but whenever you find this type of graph or in the ventilator, you try to ventilate in such between the UIP and LIP. Now what happened later on, in 2000, the landmark paper published based on the basic principles and based on the ventilator setting, and they tested 2 protocols, one with the lung protective ventilation and other with the conventional ventilation. The basic difference between the lung protective ventilation, the 6 ml per kg tidal volume was used, and the usual practice of 12 ml per kg tidal volume was used. The plateau pressure was restricted to 30 years, it was restricted to 50 years, and the peak was used according to the protocols which is here, which is in the net also, and here also the peak was used according to the oxygen criteria. The actual peak used average was 8.1 and here's the 9.1, and we can see the result. The survival was 31% in non-protective ventilation and 39% in the severe. The mortality was 31% in the 6 ml per kg body weight and 12 ml per, almost around 41% in the 12 ml per kg body weight, and it was significant. So, starting from the basics up to the clinical practice and the evidence suggests that a low tidal volume ventilation in ARDS patient is beneficial. So, what we can deduce and what is the inference to remove all the confusion regarding the tidal volume setting in ARDS patient? Almost all trials, which before the ARDS NET trial, after the trial, and after that also a Cochrane analysis has shown that the 6 ml per kg body weight or even 5 or 7 ml per kg body weight is the standard of care of tidal volume when you ventilate ARDS patients. So this is one part of the ventilating of ARDS patient, how to set the tidal volume. Now what are the consequences of low tidal volume ventilation? If the patient is ventilated with low tidal volume, the patient might have hypercarbia, patient ventilator asynchrony, more sedation and hypoxemia. Hypercarbia mostly is well tolerated, except in certain situations like where it is a contraindicated. A patient who is trauma patient, who has got a brain trauma, they will not tolerate hypercarbia. Pregnancy, they will not tolerate hypercarbia. So such type of patients are obviously not a candidate for low lung protective ventilation. Patient ventilator asynchrony also sometimes a problem in low tidal ventilation. Patient may require more sedation. Hypoxemia, very important point. Look at this graph. These are again taken from the ARDS NET trial 2000 study, and the 12 ml per kg body weight has got a better oxygenation in the first 3 days. However, and the 6 ml per kg has the lower oxygenation, but at the 4th day, the both has got the same oxygenation, and the 6 ml per kg body weight has got a better survival. So, you have to tolerate a slight degree of hypoxemia. It is not going to harm to the patient. Do not try to correct the oxygen level and do not try to normalize the oxygen when you are trying to ventilate such patient. So, acceptance of a slight degree of hypoxemia is a role in a patient when we are trying to ventilate with lung protective ventilation. So how to achieve a lung protective ventilation? You can find in almost all books nowadays, because it is the standard of practice. You start with volume and assist control mode, set a tidal volume of 8 ml per kg, predicted weight, reduce the tidal volume 1 ml per kg until we achieve a 6 ml per kg body weight. Never try to start a 6 ml per kg from the start, because the patient might have acute hypercarbia. So, and respiratory rate you set according to your goals, and also plateau pressure less than 30. When you find that the patient has got a very low pH, you can increase the respiratory rate, or the patient is hemodynamic compromised, you can have a short-term infusion of sodium bicarbonate also. And this is how you are going to calculate the predicted body weight of the patient, which is given in every book. Now come to the outpatient. Again, the outpatient has got an initial ventilator setting of tidal volume 400, FiO2 peak of 16, plateau pressure less than 30, IASO1, sedation and inline suction. But what we found that the lactate was rising and the CXR was worsening. That means even after putting the patient on conventional ventilation, the patient's condition has not improved. In fact, is it worsened due to hypoxemia. Now, what are the options? Now we are moving to the second tier of the management of ARDS. What are the options we have in such type of patient? The options will have a high peak paralysis or decrease the tidal volume because the pressure is going high, or the put the patient on pressure control ventilation with inverse ratio ventilation, recruitment or high peak, go for a prone ventilation, or continue with the same setting. There are different options we have. Now, the target, we know that the patient with ARDS will have a PO2 of more than 60 or PO to FiO2 ratio more than 100 and plateau pressure if less than 30. If your patient is maintaining this target, there is no need to change the ventilation. We can continue with such type of ventilation. But obviously you will be worried if your patient is not maintaining the target. So PEEP, pressure, PCRV, paralysis, prone ventilation, inhaled nitric oxide. These are the first line rescue therapy that can be selected based on the patient's criteria, based on what are the gadgets you have available, based on what experience you have to manage such type of patients. Now look at how the PEEP is going to act. I will not go in detail of this, but how the PEEP acts is that here the patient is not being ventilated without PEEP, and here the patient is ventilated with PEEP. You can find that if you apply adequate PEEP or optimum PEEP, which is always a matter of debate, the patient will have open alveoli and reduced alveoli that will decreases the plateau pressure and improve the oxygenation. This is the physiological benefit of PEEP when you apply. But the most important question, how to select the PEEP? What is the optimum PEEP? We do not know what is the optimum PEEP. Sometimes you can choose by FiO2 or PEEP table. You can go for a point of maximum alveolar recruitment. We can also go which PEEP is acting as better oxygenation. We can also choose according to the peak inspiratory pressure or also choose according to the stress index. Nowadays, people have used different criteria also. In advanced center, people are using a transpulmonary pressure. So you are putting a esophageal pressure monitoring and you measure the PEEP and you choose according to the transpulmonary pressure. That has helped sometime. And this is the stress index that can also be used. Here, the flow time and the pressure time curve. If you take a vertical line from the flow and where the flow is stable and you come down at the pressure time curve, you find that if it is concave downward, you still have a scope for the peak, unless and until it is going up. If it is concave upward, it indicates that there is some over distension and you should try to decrease the peak in such situations. So this is also a bedside method. You need to paralyze the patient and make a constant flow. The most new method where we can select a bedside PEEP is that electrical impedance tomography. Electrical impedance tomography basically converting electrical conductivity into the image. And if you can see, the regular ventilation comes with this type of machine. And here, a 15 PEEP, 10 PEEP, 5 PEEP, 0 PEEP. Higher the impedance, higher the volume, more the lung volume. That can be actually calculated on the bedside, and people are using this technique also to set the optimum PEEP. So there are different ways of setting the PEEP. But the more important what I am going to discuss now is the high PEEP ventilation is going to benefit to the patient or not. Suppose somebody is ventilating a patient with higher PEEP, and this was answered by a randomized control meta-analysis of 3 randomized control trials: LOVE trial, Envolite trial, and Express trial. All these trials has inference that if you apply a higher PEEP, that might improve the oxygenation of the patient, but has not improved the survival of the patient. So where are we? The PEEP should not be taken as to improve the patient's survival, number one. Second, if the patient's condition is not improving in terms of oxygen, we can even use higher PEEP. At least it is not harmful, although it is not improving the survival, but it will improve the oxygenation of the patients, and that is the effect of high PEEP. Now, recruitment maneuvers. Many people would like to do the recruitment maneuvers, applying a high transpulmonary pressure for a very short period of time, which opens the closed alveoli and improves the oxygenation. But what is the ground situation? See, the recruitment has 2 effects. It can cause distension of the alveoli, can precipitate ventilator-induced lung injury, can decrease the cardiac output, and also can decrease the oxygen delivery. Also has got beneficial effect. Alveolar recruitment can increase the PO2, also can minimize the ventilator-induced lung injury if the recruitable lung is there. Unfortunately, we do not know which patient is going to respond which way. Some patients might respond this way and they might die because of the barotrauma. Some patients might improve in this way, and the patient will might improve and will be able to win up the patient. This is the most sad part of the recruitment management. We do not know how the patient is going to respond, and more important, this is the CT scan, how the patient looks after getting the recruitment, before and after recruitment. The basal collapse and villi has improved. So the effect of recruitment maneuver is inconsistent, both in terms of oxygenation and in terms of response rate also. So this is not a method of choice for ventilating an ARDS patient, at least nowadays. It was there before. Now, neuromuscular blocker, most of the anesthetists, intensivists will like to use a neuromuscular blocker in patient with ARDS with two reasons. Because one, they will find that the patient is not having dysynchrony with the ventilation, and second, somebody also, some people and the practices intensivist has found it improves the oxygenation. What is the impact on survival? Before this trial, which was published in 2002, trial accuracy trial, there was no any evidence that neuromuscular blockade improves the survival. This was the first trial which says that if you use a neuromuscular blockade in ARDS patient in first 48 hours, those who has got a severe hypoxemia, PO2 less than 150, they will have a better survival. So, reason for better survival is three. More ventilator, basically they have found that the better survival is due to the better synchronization of the ventilation and less barotrauma because of the ventilating this patient. So now we are slightly clear about from how long duration we will give the neuromuscular blockade and which type of patient. But there are certain limitations. This trial, they used cisatracurium as a neuromuscular blockade. Whether it was the effect of cisatracurium or any blockade can produce, that is not clear. PC inverse ratio ventilation, there are some intensivists you will like to choose pressure control ventilation. It actually improves the synchronization with the patient, but and has got no effect on the patient's survival. But if your patient is not improving in terms of oxygenation, you can try a pressure control ventilation with inverse ratio ventilation. Inverse ratio means inspiratory-expiratory ratio, anything which is more than 1:1 is called inverse ratio ventilation, and putting the patient on inverse ratio ventilation actually increases the mean airway pressure, and that improves the oxygenation in such patients. But you should be very much aware about the complications of inverse ratio ventilation. Most important is barotrauma and also dysynchrony. Prone position, very important nowadays in talk of the town, because in the last 2 years it has changed the outcome of the ARDS and actually had changed the practice of management of ARDS. It was first described by Gattinoni et al. In 2001, who in his very elegant paper, he concluded that it improves the oxygenation, and the rise in oxygenation is actually sustained, and there is no rise in the mean airway pressure. It is lever intensive, 20% response, and there is a high incidence of potential complications. That was the inference of 2001. And this is how prone position physiologically works. If you are proning the patients, the heart weight goes on the upper part, and it improves the BQ mismatch, it improves the collapse unit, and it improves the hemodynamic. That's how prone positioning works. Most important thing, if you apply a prone position, the mean airway pressure does not rise. So there is a less chance of injury related to rise in mean airway pressure. So, but what is the effect on survival? Because we are looking for the effect on survival, we are not only looking for the oxygenation. So Singh et al. In 2010 did a meta-analysis, and he found that if you do a prone positioning to those patients who has got a severe ARDS, they have better survival chance. And based on this meta-analysis, the study, or Proseva study, which was published in 2013, which was done, and which was a very, very important study from all the intensives, because of two things. It has got a 16% versus 32% mortality rate. That means almost 50% reduction in the mortality in such patients who has got a prone. And most important, The prone positioning does not require any extra cost. Just you have to prone the patient, have some gadgets and prone the patient. So, based on this, the prone positioning saves lives in severe ARDS and 16% mortality at 21 days. That means almost 17% absolute risk reduction and 50% reduction in mortality. It is now also going to be a part of standard of care in ARDS patients. Many patients who has got severe hypoxemia, the next step on conventional ventilation is prone positioning if he is not improving on the conventional ventilation. So in our patient further management, we paralyzed the patient. Patient was put on PC mode with IRV, inverse ratio ventilation. Patient was given a PEEP, but there was no response to oxygen and the further plateau pressure started rising. So what to do next? This is a very, very tricky situation and also very complex situation. You have tried a first rescue therapy and the patient is not improving. What options we have now? We can continue with same strategy if you don't have any other gadgets, or we can do a transtracheal oxygen that at least improve the oxygenation of the patient. You can go for alternative mode of ventilation, or you can go for an alternative mode of gas exchange. Now what are the alternatives we have? Airway pressure release ventilation and high frequency oscillatory ventilation, that is on the ventilator part, or extracorporeal support, ECMO, or extracorporeal CO2 removal, that also can be tried in such patients. Let us see what we did in our patients. Before that, a little bit about the airway pressure release ventilation. Actually, when you are starting airway pressure release ventilation, you should have some idea what is this. In airway pressure release ventilation, you use two levels of CPAP. One, we are using a lower CPAP, and other we are using a higher CPAP. And two times, one is the T high and the other is the T low. So, you keep a higher T high for a higher CPAP, so that the patient will have a constant level of recruitment. Besides that, it also allows the patient to take a spontaneous breath at whether on T high and T low. This constant spontaneous breath allows to more fluctuation in the intrathoracic pressure, and so it minimizes the rise in intrathoracic pressure. So what we needed for an APRV mode? APRV mode patient should not be paralyzed, number one. If you paralyze the APRV mode, it is going to act as an inverse ratio ventilation. So never paralyze the APRV ventilation. And the inverse ratio is almost always 6:1. But because of the spontaneous pressure or spontaneous ventilation, this patient will have lower rise in intrathoracic pressure. So that if you have this mode, you can try this mode in ARDS patients. The second is the high frequency oscillatory ventilation. What is high frequency oscillatory ventilation? It is ultra protective ventilation. It gives a tidal volume of 1 to 2 ml of per kg body weight, but have a respiratory rate of around 300 per minute. So that keeps the alveoli open, and this tidal volume is responsible for ventilation and gas exchange in such type of patients. See how it works. If you look at the graph, here you have high frequency oscillatory ventilation. Here you have the CMV or control mode of ventilation. Because of low tidal volume, it is almost in the lung protected zones. But what is the clinical evidence we have for the high frequency oscillatory ventilation? This was the first publication of high frequency oscillatory ventilation, MOAT trial, which has shown that there is little bit survival benefit, not significant if we are putting the patient of ARDS with severe hypoxemia and high frequency oscillatory ventilation. But it was some next, which was published in 2012, somewhere disappointing. Two trials, the OSCILLATE trial and OSPER trial, very important trial, large number of patients. The high frequency oscillatory ventilation was used in early stage of ARDS, considering that it might improve the survival, but unfortunately that was not the case. So where is the current position of high frequency ventilation? The high frequency ventilation is not for the routine use of ARDS patient, but yes, if your patient is severely hypoxemic and the oxygenation is not improving, you can try if you have high frequency oscillatory ventilation. It has got its own complications. Inhaled nitric oxide is another which can be used in patients with severe ARDS or hypoxemia. How it works, if you look at this is the ARDS lung, where if you look, this lung is collapsed. So this lung is not taking part in this alveoli is not taking part in the gas exchange. If you start a nitric oxide in such patient, it will cause selective vasodilatation in this area, and you will have a better BP mismatch that will improve the oxygenation, as well as because of the selective vasodilatation, it also improves the pulmonary artery pressure, which is also an important factor for hypoxemia in a ARDS patient. So this can be used. Although there is no survival benefit, it improves the oxygenation. So what we did in our patient, the patient will continue with sedation and neuromuscular blockade, stable hemodynamics, put on high frequency ventilation, but there was no improvement in patient's condition in spite of putting the patient. This is the patient, we put on high frequency ventilation and nitric oxide simultaneously, and there was no improvement in such patients. So what to do in such situations when the patients you have tried all the ventilation strategy, and in spite of that the patient is not improving, or the patient is developing some complications like barotrauma or subcutaneous emphysema, what our patient had. So now we have other options. It was not there I think before 2009, or it was there but not in use before 2009. H1N1 has really explored the possibility of VV ECMO, veno-venous ECMO, or extracorporeal membrane oxygenation in such type of patients. What ECMO does, it actually gives full rest to the injured lung, which is required for the lung, number one. And it takes the oxygenation away from the lung, and it is getting oxygenated from the extracorporeal circuit. So in principle, it is a very, very effective treatment for ARDS patients. But indications are severe hypoxemia, refractory acidemia, and excessive high inspiratory plateau pressure. If any patient who put on conventional ventilation and you have tried all these things, patient is not improving within 48 hours of starting, so these patients are candidate for extracorporeal membrane oxygenation. This is our patient. We put the patient on ECMO. This is the ECMO machine, and this is the ventilation. What you do with the ventilation when you put the patient on ECMO, you are doing a very, very minimal setting. For example, you are setting a tidal volume of around 100 ml. You are giving a respiratory rate of around 10 or 6, or you are giving a FiO2 of around 30%. This is the ventilator setting you will achieve if you put a patient on ECMO. By putting the patient on ECMO, you find that the patient's condition started improving, and we continue with the ECMO, but we have to little bit cautious about using the ECMO, because you are using extracorporeal circulation. You will have always possibility of bleeding, cannulation injury, heparinization, related injury, and embolism. This is the one patient. You can see how the patient has got thrombosis, and then we have to explore the things. So that is also a possibility. What is the evidence? There is not, I can say, very robust evidence for the ECMO. But we have some evidence that if you start ECMO in a selective patient, it improves the survival. And this is the seizures trial, which actually brought the ECMO in the picture. And the seizures trial, if you look, the patient who was on ECMO has got a 37% mortality in comparison to those who are not ECMO, where the 53% mortality. And based on this trial and many other studies, now ECMO is the choice for using in a patient who has got a refractory hypoxemia. This is the graph of our patient when we started it, PCV and in such. Here we started ECMO to our patient, and we find that after placing the patient on ECMO, the PO2 started rising, and patient was weaned off from the ventilation as well as from the ECMO. And finally, his patient who was discharged from the hospital last, I think 2 years back, was discharged decannulated. So fluid management I am not going to talk because of the limitations of time. So what we have nowadays for the treatment of ARDS, we start with the lung protective ventilation. This is the one strategy. which has shown benefit in almost all patients of ARDS, has got survival. If your patient is not improving, you optimize the patient with PEEP and paralysis. If patient is not improving, you go for a prone position ventilation. Still, if you need further support, patient is not improving in prone position, then you can have the ECMO as a choice. Thank you for your kind listening.
Thank you, Dr. Vinod. You presented a very good topic and most discussing topics. We are always confusing the mentality of the patient with the refractory autopsy.
Yeah, that is
But a lot of information that is important. And I think all of the delegates also get this one. Now this topic is open for discussion.
Yeah.
What is your personal experience of prone ventilation? How frequently you use in ARDS?
Sir, we are using quite frequently. Actually, all those patients who are not improving on the conventional ventilation, we are going for prone ventilation. Even at this time, when I am here, at least 4 or 5 patients in my ICU is on prone ventilation, and 1 patient is on ECMO. What to do in prone ventilation, which is obviously labor intensive, but when you are doing a prone ventilation, you have to take certain precautions and most of the airway precautions. And we keep the patient in prone ventilation for almost 20 hours. That means a long time for prone ventilation. And we have seen very good response. In fact, 2 young women in the age of 20-25, we have saved their life with doing the prone ventilation, and still 4 patients on prone ventilation.
You need different type of bed.
No, nothing is required. You just prone the patient. And what you need to support the neck either by applying a pillow in this area, or you apply some pillow in the abdominal area so that to remove the abdominal pressure. There is no need for any other type of bed for prone ventilation. We are not using any extra thing for the prone ventilation. And usually it takes 4 or 5 days. That means at least you have to go for a 4 or 5 proning session in such patients. Yeah.
Any work is being done in the use of liquid ventilation or use of iVox in ARDS?
No, liquid ventilation iVox now is, I think, is out of practice now, because that has not shown any benefit to patients with ARDS. So people are not using liquid ventilation in such.
And the use of iVox in ARDS?
I don't have any idea for using iVox in ARDS. Yes.
Can you use inverse ratio ventilation in place of 6:1? Can you use 4:1 or 3:1 to avoid a barotrauma? So you are told that we should better to use.
You asked this question. I'm very happy. 6:1 ratio inverse ventilation is only used in APRV mode, because you are doing a spontaneous breathing in such patients. Okay, it should not be used in a PC control mode, because then patient will have barotrauma and patient will die. The maximum you can use 3:1 in PC control mode, but in APRV mode you can use 6:1, because the patient has got a spontaneous breathing, so intrathoracic pressure is not going to rise. And if you are using a 6:1 in this patient, never paralyze this patient. Otherwise, it will become a 6:1 inverse ratio.
So initially you should start gradually.
You start with 3:1 and go up to 6:1, depending upon your oxygenation response.
Sure. Yes.
One more thing, we again started. We are using prone ventilation in our. We are using this prone ventilation in our ICU at Paras also. Although we are started using this prone ventilation, and although we know that ECMO is not available in this part of in this zone. So at least everybody is now knowing about the low tidal volume and high PEEP ventilation. So at least because most of them are coming from the Darbhanga or Motihari or somewhere else, at least they can start with the prone ventilation. It's easier What we are doing at the evening, we are putting patient on the prone. In the next morning, after 16 hours, we are just trying to keep him in the supine. So that at least when the patient's relative come, they will see the patient in the supine position.
Now, what I will add to Kishore, what we do, we start proning in the morning, because morning the manpower is very good. So we start proning in the 8 o'clock or 9 o'clock in the morning and try to supine the patient in around 8 p.m. in the evening or 7 p.m. So that what we found, the doctor and the residents and the consultants and other people are around when we are proning the patient. And once you have prone the patient, I don't think most of the complications occurs during the procedure. If you have taken care of the procedure and patient is deeply sedated, paralyzed sometime, nothing is going to happen to the patient. You will find better blood pressure, you will find better oxygenation in such patients. So a better idea what we do is in the morning time. That evening time also can be done. There is no problem during morning, evening, but because of the manpower we do in the morning.
And I just want to, this is an interactive session. I really want to let the backbenchers should participate by asking questions, everything.
So I would like to know, we all know many strategies for ventilation in ARDS, but is there any road for non-invasive ventilation to start with?
See, non-invasive ventilation is controversial in ARDS. I will tell you why. One, because it will actually delay the intubation rate in ARDS patients, and that delaying intubation can cause mortality. In full-blown ARDS, I have not seen any patient responding to non-invasive ventilation. I have ventilated the patient for non-invasive for 2 days, 3 days. Most of the patient is going to land up in a intubation and ventilation. Unfortunately, if you are using non-invasive out of the ICU, this patient is going to die because of the delayed intubation, number one. A non-invasive ventilation, a progressive hypoxemia, if the patient has reached at a critical time, the patient will have an arrest at the time of intubation. So, do not wait that non-invasive ventilation is going to help in ARDS patients. If the lung compliance is so poor, I don't think it is, at least in some literature they have shown that can be tried mild ARDS, but mild ARDS can be managed with oxygen. Even oxygen, high flow oxygen can manage the mild ARDS. Why to go for non-invasive ventilation? Number one, if you are using a non-invasive ventilation, never use BiPAP because the flow rate of BiPAP is very low and they require very high BiPAP. So you have to use a compressed ventilation which is used for which has been built for non-invasive ventilation. So BiPAP is not going to help. Sometimes inside the ICU, you can ventilate the patient with your ventilation with mask. Or you can try for 24 hours. That's what I can suggest in such situations.
Dr.
Yes,
Vinod?
yes.
Sir, you have said there is no benefit of high PEEP in ARDS patient.
Yeah.
Then how much PEEP is to be applied?
See, you can best if you are having a not having many gadgets, you go by the ARDS net PEEP FiO2 table. Okay, we have both high and low PEEP tables. If you are using a FiO2 of 5.5, then how much PEEP should be given? If you are using a FiO2 of 1, then how much PEEP should be given? This table has been nicely given by the ARSNet study group that you can use. Other things you can use is that if you are trying to use a PEEP and you are using an incremental manner, if you find that the rise in pressure, that means the plateau pressure, is lower than the expected rise due to the PEEP, you can increase the PEEP. But any case, never use a PEEP more than 20. That is not going to benefit your patient. Yeah.
Dr. Vinod, I just have a query, and in fact I like your comment. Recently there is a resurgence in prone ventilation. So should we not use prone ventilation much earlier than what most people are actually advocating, even for mild response?
Yeah, actually, if you look at the Gatanoni trial, he used prone ventilation in the earlier, much more earlier one, and many studies published in a early prone ventilation. And finally, the Sood meta-analysis in 2010 came that if you are using a prone ventilation in early ARDS or in a severe ARDS, okay, if the patient has got a PO2 FiO2 ratio less than 150, or those patients who has got a PO2 FiO2 ratio more than 200, in a patient who is mild to moderate ARDS, whether you use a prone ventilation or whether you are using a supine ventilation, that is not going to change the outcome. The only outcome change they have found in Proseva trial in a severe ARDS patient, hemodynamic stable, using a prone ventilation for more than 16 hours, they have found that the patient will benefit in such situations. So mostly according to the present evidence, if you are using a prone, you use early, but in a severe ARDS, not a mild to moderate ARDS patient. And severe, they have defined a PO2 FiO2 ratio less than 100. Thank you.